Yes, we are looking at questions from cardiovascular and respiratory systems. And let us try to learn how to approach them as well. Okay, guys. So let's look at the first question. Let me start looking at the first question. I'm just checking the audio, video, everything is all fine and looks very fine to me from here. Okay, so everything is all fine here. So let's start looking at question 1. Jay Sudhir just has started now. Just started now. And okay, guys. So let's look at the questions. So question number 1. Let me see. Okay, so please, someone from the technical team ping me in the YouTube as well if I'm able to see the chats of YouTube. Just want to confirm that. Okay. Okay, guys. So how to approach the question? Already after discussing so much with me, guys, you would have realized this. Always when you have a question, start especially with a lengthy question. What do? I always start with the last line of the question. So what is the last line of this question here? Yes. So what is the last line I am looking for? Okay. Last line of the question. Which of the following is most likely condition associated with her finding? Okay, so they are asking which of the following is most likely associated with her. Is everything all well? Associated with her finding. Let me just check if audio video is all fine. So I'm checking it on the app first, guys. Let me just check. Guys, let me just check. Okay, so looks everything is fine. Just a minute, sorry guys, let me just check audio video both sides. On the app it is coming absolutely fine now. Okay, somebody. Okay, so let me start with this question now. What is the question here? Most likely condition associated with her finding. Now I think audio went. Is audio fine now? Please check. Is audio fine now? Please check. Sorry guys, I am taking it because okay, everything is great. Yeah, so let's start with I'm not able to hear my audio in my phone, that's why I was just worried. Okay, I'll re-log in probably. Yeah, looks fine. Okay, so most likely associated with her finding option: hypertensive emergency, type 2 diabetes mellitus, hypercholesterolemia, adult polycystic kidney disease, right? Okay, so let's look at what is the question now. Question says 44-year. So basically 4 options are given to us. One is hypertensive emergency, diabetes is given, and hypercholesterolemia and adult polycystic kidney disease have been given, right? Okay. Okay, so let us look at this now. What is the question? 44-year-old woman dies of consequence of a stroke. So they have already given us she died of stroke. She had stroke, right? At autopsy, she is found to have a large right basal ganglia hemorrhage. So basically, this is a hemorrhagic stroke. Anybody? What is hemorrhagic stroke? There would have been a vessel ruptured in the brain and that would have caused a stroke, isn't it? Yes. Okay, next. She had an enlarged 550-gram heart at autopsy. Okay, if the heart is 550-gram increase, normal weight is up to 350 grams, by the way. So if the heart is enlarged, then what? It is suggestive of hypertrophy, isn't it? Yeah, we studied this in general pathology. Hypertrophy, best assessment pathologically would be weight of the heart, right? Yes, which predominantly is left ventricle. Oh, they have already given to us which predominantly is left ventricular hypertrophy. Kidneys are small, 80 gram each. Why are kidneys small in hypertension? This will be due to fibrosis happening. Yes, correct. Renal changes because of hypertension. There can be, yes, so all these are hypertension. Okay, stroke can happen as a complication of hypertension. Then there can be LVH, left ventricular hypertrophy, as a complication of hypertension. Even small shrunken kidneys also due to hypertension with cortical scarring. In kidney, there will be hypertensive changes. There will be narrowing of the lumen of the vessel, and because of that, there will be ischemia, infarction. Ultimately, leads to fibrosis and scarring, isn't it? And there is a cortical scarring. Microscopic examination of the kidneys as given in the image. So looking at it, okay, can diabetes cause multiple things like multiple organ involvement, like kidney involvement, heart involvement, and stroke? Answer is yes, but diabetes is more likely to cause atherosclerosis, which will lead to MI and can lead to thromboembolic stroke rather than a hemorrhagic stroke, isn't it? And what is the kidney biopsy showing here? Look at the kidney biopsy finding. What you're finding in this? This is your, what is this, which I showed this in the class, guys? Have you identified what is the finding here? This is your onion skin appearance. Onion skin appearance of, so of malignant hypertension. So my diagnosis will be a malignant hypertension here, isn't it? Malignant, HTN I'm writing, malignant hypertension, isn't it? Yes. And benign hypertension would have shown a hyaline arteriosclerosis. Onion skin appearance, pathologically we call it as a hyperplastic arteriosclerosis. So the diagnosis here will be hyperplastic arteriosclerosis. Hyperplastic arteriosclerosis is the diagnosis here. Okay, so what is your diagnosis? Ultimately, answer is hypertensive emergency. Hypertensive emergency. No audio is not heard. No audio in my phone. I'm not getting it. Mahinder, I'm not getting audio in my phone, in the app. हाँ, ये डिफॉल्ट करना पड़ेगा ना, तभी तो आएगा। हाँ, तो अभी नहीं आ रहा है ऑडियो? नहीं, अभी पहले ये किया था ना, इसलिए नहीं आया था। अभी मेरे इसमें तो नहीं आ रहा है, तुम्हारे इसमें आ रहा है ऐप पे? हाँ, अभी डिफ़ॉल्ट पे कर दिया ना। अभी डिफ़ॉल्ट पे ही रखो इसको। ठीक। Okay guys, so there was some issue. Yeah, now everything is sorted out, I guess. Okay. Let's look at next question. Question number 2. No, again the sound is not there. Just a minute. Is it audible now? And we are trying something new, that is why this issue is coming. Is it audible now? Yeah. Okay, thank you. Okay, so now everything is fine. Is there again an issue? Yeah, again there is a issue, I guess. Let me just check it, sort it out. Yeah, again there is. Sorry, intermittent it is. Okay, guys, just a minute. Give me a second. बीच बीच में आ रहा है, जा रहा है, कट रहा है ऑडियो. फोन पे चेक करो, इसमें चेक करो. क्या, किस में? फोन पे. Okay, now is it okay now? नहीं नहीं, बीच में कट रहा है, देखो नहीं आ रहा है. यहाँ से यूट्यूब में बंद कर दूँ इसको, ये स्ट्रीमिंग बंद कर दूँ OBS से. हाँ, ये आ रहा है, अभी आ गया. वहाँ पे आ रहा है कि नहीं आ रहा है? इसको बंद करना है कि नहीं करना है इसको? नहीं नहीं नहीं, उसमें OBS में से स्ट्रीमिंग को. ओके ठीक है, चेक कर लो दोनों जगह पे है कि नहीं. Okay, sorry guys, let me just check it now. Is it okay now? Okay, ठीक. Okay, now I think. Okay, okay. Now it is on the app. It is working well. Okay, guys. So this was your malignant hypertension. So what if it was a diabetes? Type 2 diabetes will show later on in renal pathology we'll be studying. It will show nodular glomerular sclerosis. Hypercholesterolemia will lead to, as you know, atherosclerosis can lead to stroke, and MI unlikely to cause a LVH. Okay. Polycystic kidney can show stroke. Yes, correct. Can show stroke. Can, because polycystic kidney can also be associated with hypertension. Later on in we will be studying that in renal pathology, but it is unlikely to, it will not show such a key change in the histology, that is your onion skin appearance or a hypoplastic arteriosclerosis, right? Yes, so this is your question number 1. Let us move on to now next question number 2. So what is the next question? Let us look at the next question. It's a one-liner question. So one-liner will not break our head too much. Straight away, which of the following is not an immune-mediated vasculitis? So word is not an immune-mediated vasculitis. Henoch-Schönlein purpura, it is an immune-mediated vasculitis. If you remember, HSP is a type 3 hypersensitivity reaction that is happening. HSP, Henoch-Schönlein purpura, right? Microscopic polyangiitis is not an immune mediated. It is a ANCA associated. ANCA associated are also called as pauci-immune. Why pauci-immune? If you remember, pauci-immune vasculitis. ANCA associated vasculitis or pauci-immune vasculitis. Pauci-immune means there is not much of immune response. Actually, there are antibodies against the neutrophils which are damaging the antibodies against the neutrophils are damaging the neutrophils, and there is a release of enzymes from the neutrophil, which is ultimately causing damage to the vessel. Kawasaki vasculitis. No, Kawasaki vasculitis has type 4 and even type 2. More common is type 4, more important is type 4, and type 2 hypersensitivity reaction. Polyarteritis nodosa is also type 3 hypersensitivity reaction. If they had given foamy cells and fatty streak in the image instead of yes, then I would have considered it as atherosclerosis, even if they had mentioned hypertension also, because hypertension and atherosclerosis go together. Hypertension itself is a risk factor for atherosclerosis. Yes, correct. If they had given an image of atheroma or a fatty streak, then you will start thinking of because atherosclerosis also can lead to aneurysms and ultimately can cause scarring of the kidney eventually. Okay, and aneurysm can also compress the renal artery as well, abdominal aortic aneurysm, leading to shrinkage of kidney there. Only one thing which cannot explain atherosclerosis was left ventricular hypertrophy, but association of atherosclerosis would be hypertension. So usually it is invariably associated with an hypertension, so that will be leading to LVH. Okay, yeah. So polyarteritis nodosa is a type 3 hypersensitivity. So which are the important examples of ANCA associated, which are post-immune vasculitis, are MPA. What is MPA? Microscopic polyangiitis. Then GPA. What is GPA? Granulomatosis with polyangiitis. And EGPA. What is EGPA? Eosinophilic granulomatosis with polyangiitis, right? So this was earlier known as Churg-Strauss. EGPA was known as Churg-Strauss syndrome. GPA was earlier known as Wegener's granulomatosis, right? So these are your important post-immune associated or ANCA associated vasculitis, anti-neutrophil cytoplasmic antibody associated, right? Okay, next question number 3. Next question, let us look at this last line. Likely diagnosis. So they are asked, what is a likely diagnosis? Yes, please tell me, guys, what is a likely diagnosis here? I am looking at the chat box. Please, yes, please tell me what is a likely diagnosis here. Very good. Even HSP is called as what? IgA vasculitis. HSP is also called as IgA. Yes. So yeah, that is what is happening. It is streaming both on app as well on YouTube. So that is why I was checking at both the places. Okay. Yeah, please tell me now. So what is the answer to this question? What is the answer to this question? What do you answer, guys? In the chat box. Please answer in the chat box. 35-year female presents with headache, diplopia, jaw claudication. Arterial biopsy shows granuloma and giant cell with fibrosis. What is the likely diagnosis? Yes, giant cell arteritis, granulomatosis polyangiitis, Takayasu arteritis, and polyarteritis nodosa. What is the correct answer in this? Okay, some people have said A, that is giant cell arteritis. Some people have said Takayasu arteritis. What is the correct answer? It is not a giant cell arteritis. Why not? Anybody? Why not a giant cell arteritis? Tell me now. Yes, please. Yes, why not giant cell arteritis? For giant cell arteritis, age is most important, more than 50 years. And this is less than that. That is why. Most important distinguishing feature between giant cell arteritis and Takayasu arteritis is age. And that is the reason why it is not giant cell arteritis. Okay. So is it granulomatosis with polyangiitis? No. GPA usually involves small vessels, not arteries, right? Artery will be the medium to large vessel vasculitis. And this is presenting with headache, diplopia. This is a typical of your, yes, this is a typical of giant cell arteritis. But however, I mean, of course, biopsy showing granulomas and giant cell, you are thinking of giant cell arteritis. Very good. More than 50 year. And usually no. Giant cell arteritis, whatever is a clinical feature, doesn't matter. Age group is important for us. Okay. So giant cell arteritis, Takayasu commonly involves subclavian artery. Okay. Commonly involves subclavian artery. That's why upper limb pulses will be absent. But here subclavian is not involved. Still, I will call it as Takayasu because of age. So age is younger, then make a diagnosis of Takayasu arteritis. Biopsy of both of them will be same. Okay. So most important distinguishing factor is the age here, right? Okay, let us look at the next question now. Next question. Yes, one liner again. Okay, let us look at it. Likely diagnosis. Examiner is asking what is the diagnosis here. Coarctation of aorta, tetralogy of Fallot, ASD, VSD. Anybody? Yes, sir. Which one is it? Yeah. So tetralogy of Fallot, coarctation of aorta, ASD and VSD. Yes. Anybody? What is a child born having cyanosis in the lower body? Upper body is unremarkable. So there is a cyanosis only in the lower body and upper body is unremarkable. What is your diagnosis here? Okay, it is option coarctation, congenital, all these are congenital heart diseases, isn't it? So what is happening if the lower body is having cyanosis? So the moment there is a cyanosis, that means this is getting a deoxygenated blood. Yes, correct. Deoxygenated blood is there in the lower body, isn't it? Yes. Why is lower body getting a deoxygenated blood? Yes. Okay. So tetralogy of Fallot, coarctation of aorta, ASD and VSD. What is the correct answer in this? Okay, how many of you thought it was a tetralogy of a Fallot here? Many of you have written it as tetralogy of Fallot. Answer is no. Tetralogy of Fallot, why will this have? See, the moment there is deoxygenated blood going to the lower limbs only, that means, and upper limb is not getting a deoxygenated blood. What could be happening? Let me try to explain you this. Okay, this is your aorta. Let us look at this is the aorta. Okay, and let me label this will be your pulmonary trunk, by the way. And okay, from pulmonary trunk there would have been what? So this is your let me try to show pulmonary trunk like this, and this will be your DA. What is DA? Ductus arteriosus. In the childhood or in the fetal life, this will be your ductal arteriosus, isn't it? Yeah, very good, very good. So the answer here, this is a ductal arteriosus. And only way that the lower limb can get the deoxygenated blood, not the upper limb, would be, so your deoxygenated blood, let me try to show it with blue color so that you can understand. From the pulmonary, there is a deoxygenated blood. It is flowing through the ductus arteriosus, and it is only reaching the lower limb. It is not going to the upper limb. Basically, what does that mean now? Tell me. So this will be your subclavian artery and the brachiocephalic trunks here from the arch of the aorta. So what would have happened here would be, yes, what is the most likely? Pathogenesis. There would have been a coarctation of aorta happening proximal to your ductus arteriosus. Yes, correct. So there is a coarctation of aorta happening proximal to the ductus arteriosus, and that is the reason why upper limb is not having any problem. Okay, upper limb is getting oxygenated blood. This is getting oxygenated blood, whereas the lower limb is getting deoxygenated blood. Very good. This is diagnosis coarctation of aorta, and we call this as infantile form. Infantile form of coarctation of aorta. So there is one more adult form of coarctation of aorta, which will be without a patent ductus arteriosus. So this will happen only if there is a PD, patent ductus arteriosus. In the adult form, how will the adult form be manifesting? Adult form will not have this patent ductus arteriosus. That is why lower limb will not get any blood. No deoxygenated blood, no oxygenated or less oxygenated blood. That's why the BP and the pulse will be low in lower limb and normal in the upper limb. That is what will be in the adult form of coarctation. In a fetal form or in infantile form, we call it, where there is a ductus arteriosus that is there, which will be patent anyway for up to 24 hours, it will be patent. And if it is patent for a prolonged time, that will lead to cyanosis in the lower half of the body. This is a classical manifestation of infantile form of coarctation of aorta, isn't it? Yeah. So very, very important. Only half of the body is cyanotic here, right? Yes. Okay, guys, how many of you got it correct? Some people have answered. Many of you have answered TOF. No, not TOF. Not TOF. Answer is what? Coarctation. Okay, next. Question number 5. Let us look at question number 5. What is this? Unstable angina is due to, one-liner question. Unstable angina is due to narrowing of lumen due to plaque, coronary vasospasm, rupture of atherosclerotic plaque, increased demand from the heart. Yes. Which one is causing unstable angina? Option A. What is this? Option A. Narrowing of lumen due to plaque. This causes a stable angina. This will cause stable angina. In fact, combination of A and D together will cause stable angina. That is a better word I would say. Combination of both A and D together will be causing stable angina, isn't it? Yes. Coronary vasospasm leads to Prinzmetal angina. Prinzmetal angina, that is due to, yeah, coronary vasospasm. So that is why, because okay, Prinzmetal angina will only respond to vasodilator. Pain will be even at rest also here because it is due to vasospasm of coronary arteries. Whereas stable angina will respond to both things. One, it will be aggravated by exercise because demand increases, and it will be relieved by both rest and vasodilator. Whereas Prinzmetal gets relieved only by vasodilator, not by rest, because it is even present at rest. Unstable angina is due to rupture of atherosclerotic plaque. Once there is a rupture of the plaque, this will also be, so rupture of the plaque will lead to platelet aggregation, plus there will be atheroembolism happening, atheroembolism, plus this will also lead to vasoconstriction also will happen here, vasospasm will happen, and this vasospasm is due to endothelial injury, and this ultimately leads to unstable angina, and the pain will be at rest also here, because even heart doesn't increase the demand, there will be pain happening. This will be also leading to pain at rest, and this will also be relieved by vasodilators, but this is having a very high potential to progress to MI, because this atheroembolism can eventually leads to myocardial infarction. Myocardial infarction. So answer to this question is option C. Option C. All right. Yes. Next, let us look at the next question. Question number 6. Question number 6. Okay, this is a repeat question which previously came in exam, by the way, guys. Okay, in a triphenyl tetrazolium staining, triphenyl tetrazolium misprint is there. Chloride should be added here. Triphenyl tetrazolium chloride staining of heart. Viable myocardium appears what color? What is the color of the viable myocardium? If you remember, triphenyl tetrazolium chloride stains LDH. Stains LDH in the muscle actually. So once it stains LDH in the muscle, and it will appear brick red in color. That will be the color, brick red color, and in this option, option B is there. Brick red color or red color. And in MI, it will appear pale. So infarcts will appear pale. Why infarcts will appear pale? Because there is loss of LDH. So this can also come as a question. Why do infarcts stain pale on triphenyl tetrazolium chloride? Because there is loss of LDH. Lactate dehydrogenase is lost from the dead cell. If you remember again from general pathology, cell injury has happened, there is leakage of content, and that will go out, and that's why there is no LDH within the myocardium, isn't it? Yes, and that is leading to this staining property. At autopsy, we use this very frequently. Okay, next question number 7. Again, a one-liner question. Let us look at this. In which of the following cardiomyopathies there is a systolic cardiac failure? Anybody? Which one is having a systolic cardiac failure? Meaning, so the moment somebody tells me systolic cardiac failure, that means there should be decrease in what? Cardiac output or decrease in ejection fraction? Which is the best measure of systolic function of the heart? Anybody? Yes, guys, please tell me which is the best measure of systolic function. There is a decrease in EF, ejection fraction of the heart. Decrease in ejection fraction. Decrease in ejection fraction is happening, right? Decrease in ejection fraction. Okay, dilated cardiomyopathy, hypertrophy cardiomyopathy, restrictive cardiomyopathy. Answer is only dilated cardiomyopathy. Hypertrophic cardiomyopathy, there will be, yes, which failure? Diastolic failure. Both of these will be diastolic failure. So in all of them, there will be decrease in cardiac output, by the way. So don't get confused. The diastolic failure, heart is unable to fill. When the heart is unable to fill, it will not be able to pump. So cardiac output will reduce in all cardiomyopathies, but decrease in systolic failure or systolic failure happens only in dilated cardiomyopathy. Same question, in which of the cardiomyopathy there is a decrease in cardiac output? What will be the answer? Please tell me. In which of the following cardiomyopathy there is a decrease in cardiac output? What will be the answer in that case? In that case, answer will be all of the above, right? So yeah, cardiac output will be decreased in all of them. Cardiac output will be decreased in all of them. Okay, just a minute. Okay, so next question, let us look at the next question now. What is the next question here? Eschof's body. Eschof's body contain all of the following except. So what is not seen in Eschof's body? T cells, okay, plasma cells. Options are T cell, plasma cell, macrophage and neutrophil. So what will Eschof's body contain? Eschof's body is inflammatory body. Yes, it is an inflammatory body seen where? Yes, it is an inflammatory body seen in rheumatic, isn't it? Seen in rheumatic, especially in myocardium, rheumatic carditis. Okay, so tell me now, Eschof's body will not see all except they are asking. Okay, T cells will be present. T cells will be present. Plasma cell will also be present. Macrophages also are present. Neutrophils are absent in Eschof's body. Apart from this, Eschof's body can contain giant cells. The macrophages are called as Anischkoff cells in Eschof's body, isn't it? Giant cell can be there. Even there, okay, giant cell will be known as what? Eschof's cells. And there can also be fibrinoid necrosis. Fibrinoid necrosis can be seen. Not neutrophils. So neutrophils will be absent in Eschof's nodule. The macrophages in Eschof's nodule are known as what? Modified macrophages are called as Anischkoff cell. Anischkoff cells are nothing but the modified macrophages that are seen in Eschof's nodule, right? Yes. So there will be caterpillar-like nuclei. Anischkoff cell, caterpillar-like nuclei. Okay. Question number 9, one-liner question. Pathogenesis of hypertensive aneurysm is. See, look at the questions that are coming. Although they look one-liner, but they are not fact-oriented one-liner. They are concept-oriented one-liner. So they are asking you what is the pathogenesis of hypertensive aneurysm. So there are two types of aneurysm, if you remember, hypertensive aneurysm and atherosclerotic aneurysm. Two important causes of aneurysm. Inflammation leading to the vessel wall weakening. No, this is not the pathogenesis. This is the pathogenesis for atherosclerotic aneurysm. Atherosclerotic aneurysm most commonly occur in abdominal aorta, isn't it? Next, direct pressure causing dilation. If that was the case, then all hypertensive patients should have developed aneurysm. That is not happening. So if direct pressure, 120 millimeter of mercury is also enough. Only the pressure would not be causing because of the elastic recoil of the arteries. That is why this is not an answer. It can be a risk factor. It is not an answer. If that was the case, all patients who are having hypertension should have developed aneurysm. That is not happening, isn't it? And that is why why it is not happening, because physiologically we all understood we have a elastic recoil of the vessels, isn't it? Because they are having a elastic laminas are there. Two laminas, internal and external elastic lamina. Death of the smooth muscle is the correct answer. So how does hypertension lead to death of the smooth muscle? Hypertension leads to vascular changes. What vascular changes? Arteriosclerosis will happen. Not atherosclerosis, arteriosclerosis. Which arteriosclerosis will happen? Either hyaline arteriosclerosis or hyperplastic arteriosclerosis. And when arteriosclerosis happens, there will be narrowing of the vessel wall, narrowing of the lumen, narrows lumen of the vessel, lumen of vessels, including vasa vasorum. What are vasa vasorum? So vasa vasora, plural will be vasa vasora. Yes. Yes, vasa vasora. So vasa vasora plural or singular will be vasa vasorum. Vasa vasorum are the vessels which will be supplying the blood vessel. So because narrowing of lumen of the vasa vasorum, this will lead to death of a smooth muscle, death of smooth muscles of vessel wall, and this leads to weakening of the vessel wall, weakening of vessel, and that leads to aneurysm. So very important. There will be hypertensive aneurysm is due to necrosis or death of the smooth muscle. Ischemic necrosis is happening. Another condition which causes like this is syphilis. Syphilis also causes obliterative end arteritis of thoracic aortic vasa vasorum. So syphilis only causes in thoracic aorta because it causes obliterative end arteritis. Even hypertensive aneurysms are also most commonly seen in thoracic aneurysm. They will be mostly thoracic. Whereas atherosclerotic will be mostly abdominal aortic aneurysms. Isn't it? Abdominal aortic aneurysms. Okay, guys. So all of you clear? Yes. Next. In fact, even in case of atherosclerosis, there might be some amount of death of the smooth muscle happening because atherosclerotic plaque becomes very thick. When it becomes very thick, there will be reduced blood supply to the innermost smooth muscles also happening there. Okay. Next. Question number 10. Small thrombotic vegetation along the lines of closure of the valve are seen in. So straightforward one-liner question. Rheumatic carditis. Answer is no, it is not rheumatic. Rheumatic will be small, correct, but there will be warty vegetation, wart-like vegetations along the lines of closure. Along lines of closure. Non-bacterial thrombotic endocarditis, that is a correct answer. Infective endocarditis, no. They will be thrombotic, correct. They will be thrombotic, but they will be large, friable, and extend along the chordiotendineae. Libman sac will show on the surface, valve surface. On the valve, on both the surfaces of the valve. That will be the Libman sac. Libman sac is nothing but lupus, isn't it? Libman sac will be lupus. Next. 11. Question number 11. Last line, lengthy question. Approach will be last line. What is the likely etiology? Hypertension, genetic, drug abuse, MI. Okay. 22-year-old soccer player collapses on field during a practice match. He died on the way to the hospital. The autopsy finding of the heart is as shown in the figure. What is the likely etiology? Yes, what is the answer here? Tell me now what is the answer in this question. Okay, what you are seeing in the image, they have given the autopsy image. I'm sure all of you would have made a diagnosis here. Look, what are you seeing here? This is the septal hypertrophy, isn't it? Asymmetrical septal hypertrophy. And there is also LVW, left ventricular wall hypertrophy happening, but it is asymmetrically more in septum. Diagnosis will be hypertrophic cardiomyopathy or HOCM, hypertrophic obstructive cardiomyopathy, which is due to genetic cause. Option B, it is due to MYH mutation. Okay, MYH mutation, and it is an autosomal dominant condition. Inheritance is, mutation is MYH most commonly, MYH mutation, and inheritance is autosomal dominant in inheritance. Autosomal dominant. Right? Next. Question number 12. Question number 12. Okay. Histological examination of an infarct is as follows. What is the age of the infarct? Yes. Histological examination of an infarct is as follows. Sorry. What is the age of the infarct here? Yes. So what are you seeing in this infarct? Anybody, what are you seeing in this infarct here? Okay, look at this. Look at the arrow marks that I'm pointing. This is nothing but your what? Coagulative necrosis. How do I identify their coagulative necrosis? I don't see any nucleus, isn't it? There's a coagulative necrosis. And look at the double arrows that I've pointed here. These are dense neutrophilic infiltrate. Dense neutrophilic infiltrate. So this will be somewhere between 1 and 3 days. The best answer here will be 3 days here, right? Yeah, if it will be 1 day, only necrosis, very less of neutrophil will be seen. If it is 7 days, you will see macrophages, no muscle only. 14 days, you will only see collagen, isn't it? Yes, so 14 days, you will see collagen. 7 days, you will see only macrophages. 1 day, you would not see neutrophils also, isn't it? Yes, correct. This is a ghost cell appearance where there is no nucleus, only the outline of the cell is preserved here, right? Next. Okay, which of the following aneurysm is due to mutation in a collagen gene? One liner question again. Okay, which is due to mutation in collagen gene? Vitamin C deficiency. Vitamin C deficiency is not due to mutation in collagen gene. It is due to abnormal cross-linking of collagen. Marfan syndrome. No, it is due to mutation in fibrillin gene. Isn't it? Ehlers-Danlos syndrome is the correct answer. Ehlers-Danlos syndrome is due to deficiency of a collagen. Isn't it? Yeah. So mutation in Marfan syndrome is fibrillin, and because of fibrillin mutation, there will be abnormal collagen elastin production. Isn't it? Yes. No, so not all of the above as well. Ehlers-Danlos syndrome. Next, question number 14. Let us look at this question now. What you are seeing in this question here. Which of the following is a primary cause of cardiogenic pulmonary edema? So what is a cardiogenic pulmonary edema? Why is it happening? Excessive fluid intake, left ventricular failure, renal failure, pulmonary embolism. Yes, tell me what is the cause of cardiogenic failure, cardiogenic pulmonary edema. In cardiogenic pulmonary edema, there will be a left ventricular failure. This leads to increase in hydrostatic pressure in pulmonary capillaries. Increased hydrostatic pressure in pulmonary capillaries. This will lead to pulmonary edema. Simple words. This is what is the answer. Yes. So answer is option B, left ventricular failure. Left ventricular failure is leading to cardiogenic pulmonary edema. Right? So cardiogenic pulmonary edema will show because of left ventricular failure, there will be pulmonary capillaries, and on histopathology, what do you see? You see heart failure cells. What are heart failure cells? Macrophages filled with hemosiderin-laden macrophages. Okay. Non-cardiogenic pulmonary edema is ARDS, correct. And we have a question on that as well. Okay, let us look at this question now. What is this? In which of the following mediastinum shifts away from the lesion? Mediastinum shifts away from the lesion. The mediastinal shift is away from the lesion. Emphysema, there is no shift in the mediastinum. Why? In emphysema, there will be both of the lungs will end up what? Getting bloated up. So no shift in the mediastinum. Pneumonia. Pneumonia is not going to shift to mediastinum. So usually the atelectasis will be resorption atelectasis and compression atelectasis. Which one will shift away? Resorption atelectasis will end up shifting towards the lesion. Resorption, because of any blockage, there will be resorption. So mediastinum shifts towards the lesion, that is towards the atelectasis. Correct. In compression, there is a compression happening to the lungs, which will end up causing collapse of the lung, and because there is a pressure which is compressing the lungs like a pleural effusion, etc., the mediastinum will be shifting. Yes, it will shift away from the lesion. What do I mean by this? Away from the lesion. Suppose imagine there is a left lung atelectasis, the mediastinum will shift towards the right. Okay. In case of compression atelectasis. In case of resorption, if there is a left lung resorption atelectasis, the mediastinum will shift towards the left only. Okay. So remember, in atelectasis, mediastinum can shift either ways, depending upon which type of atelectasis is there. Okay. Next, question number 16. Let us look what is this. In ARDS, which of the following is the most common underlying mechanism? So what is happening in ARDS? Increased hydrostatic pressure in pulmonary capillaries. No, this is happening in cardiogenic pulmonary edema. This is not in ARDS. ARDS is non-cardiogenic pulmonary edema, isn't it? So this is happening in cardiogenic pulmonary edema. Henceforth, we'll write short form CPE. So non-cardiogenic pulmonary edema will not have this. Damage to alveolar capillary membrane leading to increased permeability. This is the correct answer. Decreased oncotic pressure. No, this will be in hypoalbuminic condition. That will not only cause pulmonary edema. Decreased pulmonary blood flow. No, this is not the answer. Pulmonary blood flow, if it is reduced, there cannot be a edema happening there, right? Yes. So straightforward question. Answer is option B. Only keyword here is, trick is you should be knowing ARDS is nothing but non-cardiogenic pulmonary edema. Okay. Next question. Obstruction in emphysema is due to So why is there an obstruction happening in emphysema? Dilated alveoli, increased wall thickness of the bronchiole due to muscle hyperplasia, increased wall thickness due to glandular hyperplasia, collapse of terminal bronchiole during expiration. See, dilated alveoli will be present. They are present in emphysema, but they are not the cause of obstruction. Not the cause of obstruction. Anything dilates, it cannot cause obstruction. Dilatation is relieving the obstruction, by the way, right? So that is not the cause. That is why it is not the correct answer. Increased wall thickness due to muscle hyperplasia. No, emphysema affects terminal bronchioles and beyond that, alveoli. So this option is also wrong. This will actually happen in asthma. In asthma, there is a muscle hyperplasia happening due to vasospasm, bronchospasm that keeps happening. There will be repeated bronchospasm happening, muscle hyperplasia will be there. Increased wall thickness due to glandular hyperplasia is also not. This is seen in chronic bronchitis. So if you remember, in chronic bronchitis, there will be glandular hyperplasia, submucosal glandular hyperplasia. Correct answer is obstruction is due to collapse of terminal bronchiole during expiration. So this is your, let me say, terminal bronchiole, and this is your alveolus. Let us say like this, only one single, and this is your TB. Terminal bronchiole is getting collapsed during expiration. Why? Because elastic recoil is lost. Elastin has been damaged, loss of elastic recoil, so it will collapse, and that is why whatever air is filled is not getting expired. That is why they will be having they will be puffing the air out, because they'll be trying very hard to exhale the air, right? That is what is. And this is also the reason why, because obstruction only is during expiration, they will never be cyanotic, so they will have adequate oxygenation level. Okay, next. Smoking is associated with centriacinar emphysema, panacinar emphysema, distal acinar, and irregular. Answer, it is not irregular. Irregular is associated with infection. Any infection, lower respiratory infection, can cause irregular. Clinically, they are asymptomatic. Centriacinar is the correct. Panacinar is associated with alpha-1 antitrypsin deficiency, congenital condition. Yes, pink puffers or red puffers, we call them emphysema. Distal acinar, no, distal acinar is associated with pneumothorax, spontaneous pneumothorax. Distal acinar emphysema. Next, read index is, so what is read index? Increased in bronchiectasis, decreased in bronchiectasis, increased in chronic bronchitis, decreased in chronic bronchitis. Read index is ratio of, yes, ratio of gland thickness, yes, ratio of the gland thickness to the wall thickness. So ratio of thickness of the submucosa, or ratio of thickness of the glands. You can say gland thickness or the submucosal wall thickness, and normal value is around 0.4. If it is more than 0.4, answer will be, it is a chronic bronchitis. It is increased in chronic bronchitis, right? Chronic bronchitis. Next, cells involved in late phase of asthma. Yeah, submucosal gland to the wall thickness is there. 0.4 is the normal value. Okay, cells involved in late phase of asthma. Mast cells, no. Mast cells are involved in early phase of asthma. If you remember, there are two phases of asthma or type 1 hypersensitivity, early phase and the late phase. Early phase typically happens within few minutes, that is by mast cell. Late phase is by eosinophils. They will secrete major basic protein and eosinophilic cationic protein, which will ultimately cause tissue damage. Right? And to counter this, we are using steroids in treatment of asthma as well, right? Okay. Question number 21. Critical size of the particle to cause pneumoconiosis in microns is. So what is the critical size to cause pneumoconiosis? If you remember, less than 1 cannot cause. Less than 1 will be soluble. So because they are soluble, they will not induce any inflammation. You will have an immune reaction to this. More than 5 also cannot cause. Why more than 5 cannot cause? Because they will be trapped in respiratory tract only. If they are trapped in the respiratory tract, they do not reach the alveoli. Answer, very good. Critical size should be between 1 to 5 micron. Anything less than 1 cannot cause. More than 5 cannot cause. So in this, look at this. More than 1 is also partly correct, but best answer will be 1 to 5 micron. It should be in between 1 and 5 micron size. Then it will be causing, it can cause pneumoconiosis. Okay. Next. Okay. Next question, image based. Okay. What do we look for? Read the question. Biopsy from the patient suffering from long-term respiratory difficulty is as follows. Likely diagnosis. So what is the likely diagnosis? There is some issue. Just a minute, guys. Yes. So what is the likely diagnosis here? Okay. Yes. What is the diagnosis in this? Biopsy from a lung in a patient suffering from long-term respiratory difficulties as follows. Sarcoidosis, asbestosis, fungal pneumonia, TB. Sarcoid and TB should be showing granulomas. Both of them should be showing granuloma. I don't see a granuloma. What am I seeing here? Okay. Yeah. What is this? Very good. So this is your asbestos body. This is your asbestos body. Fungal pneumonia, there should have been a fungus, or also called as ferruginous body. Correct? Okay. Ferruginous body. So diagnosis is option B, asbestosis, which will cause a restrictive lung disease, right? Okay, next question. Let us look at the next question now. Likely diagnosis. Small cell carcinoma, adenocarcinoma, squamous cell carcinoma, carcinoid. Tumors are the question in the option. Chronic smoker presents with weight loss, cough, serum calcium is increased. Biopsy shows a malignancy. Likely diagnosis. Okay, keyword weight loss, everything will be there in any of the carcinoma. Okay, I rule out carcinoid here. Carcinoid, usually lung carcinoids are benign in nature. Weight loss, cough will not be happening, and anyway there is a malignancy given. Carcinoids are benign tumors. Usually in lung they are benign, not malignant. Okay, so what is the answer now? Small cell, adeno, squamous cell. Which one is it? Look at this. The keyword is calcium being increased. Answer will be a squamous cell carcinoma. So this is a paraneoplastic syndrome. Usually remember this. Paraneoplastic syndromes are usually associated with small cell carcinoma like SIDH, Cushing's, etc. Small cell, except for hypercalcemia, which is associated with squamous cell carcinoma of lung. Okay, so answer here is squamous cell carcinoma. Right? Good. Keyword calcium is increased. Oh, how come this question got repeated again? 22. Okay, sorry guys, there is a misprint in this question. They have changed the image. So in the paper also it came like this. Just a minute, let me just take the test. In the test also it came like this. Please tell me. Okay, anyway, there was an image, different image was there. That's why. Just check in the test also. Okay, so sorry guys. So this question is a bonus one now because the image is of asbestosis here. Anyway, if at all question, if asbestosis will lead to which carcinoma? Adenocarcinoma. Okay, asbestosis would lead to adenocarcinoma. So likely diagnosis, biopsy from the lung is as follows. Which risk factor is there? Adenocarcinoma. Anyway, image is I had given of a small cell carcinoma image, so there is somehow misprinted question. Okay, a lung malignancy which is positive for TTF1 and NAPSIN-A is. Yeah, so if asbestosis will lead to adenocarcinoma of lung, if that is a question asked. But anyway, I had not given that question. I had given a question of some other image, small cell carcinoma image there. Okay, TTF1 and napsin. Napsin-A is a marker for, yes, it is a marker for type 2 pneumocyte. Type 2 pneumocyte. And which tumor arises from type 2 pneumocyte? Adenocarcinoma. That is the correct answer. Okay, adenocarcinoma. Yeah, so these were questions from cardiovascular and respiratory system. I hope you guys have enjoyed these questions. Questions were looking very simple, but some of them were tricky as well. Okay, yes, so I'm seeing many of you are attending. Jay, how did you like the class? And all others, I hope it's your DBK is your pseudonym. And I'm seeing Suman, and then I'm seeing Abhiman, sorry, no, Abhinnaman. Okay, guys. So how is questions were simple, not very tough, but they were tricky as well sometimes. Any other doubts? If you are having any other doubts, I can take your doubts now. And after going through the class, you would have had many doubts as well. If you are having doubts, use this revision sessions to clarify your doubts. Okay, so I don't see any doubts then. Good luck, guys. See you in the next class. Thank you. So Dr. DBK, thank you for your appreciation. Yeah, so next month we'll be having another session of the next two systems, whatever systems that will be given to you. Another 25 questions will be there. Okay, guys.